Welcome to Better Sex, where you get the information and inspiration to create and enjoy your best possible sex life. Join your host, sex therapist Jessa Zimmerman, as she brings you expert guests, helpful tips, knowledge, and strategies to improve your intimate relationships. And now, your host, Jessa Zimmerman.
Hi, everybody. I'm Jessa, and I'm so happy you're here for this episode of Better Sex. I've dedicated my professional life to helping couples enjoy a fulfilling, intimate life. I believe that sex is important. Our connections to other people matter, and we're not living our life to the fullest if we aren't connecting emotionally and sexually with our partner. That's why I'm here, bringing ideas and information to help you live and love better.
I'm so excited for today's episode. I mean, maybe I say that every week, but this one really I have been waiting for. We're going to talk today about pelvic floor physical therapy. And the reason I'm excited is because this is the number one referral I make out of my sex therapy practice. This is so vital to sexual health for people. It is crucial that somebody that is dealing with sexual pain sees a physical therapist. There are so many ways that PT can help those conditions and can be the one really to almost diagnose and understand what's going on, that is crucial. But it also deals with all kinds of other complaints and symptoms and concerns that can affect people's sexual health, sexual well-being, their relationships. So incontinence and pain and all kinds of things. I am talking today to Dr. Serena Fiacco. She is a licensed physical therapist and a board-certified sexuality specialist. So she holds a doctorate degree in physical therapy and a doctorate degree in human sexuality. So she has married these two worlds and is so passionate and informed and effective in helping people with these concerns. So she specializes in the treatment of pelvic floor and sexual health conditions. And in addition to that clinical work, she teaches sexual health courses to the community and university groups. She's just a delightful person. She happens to be in Seattle, so I actually refer to her personally a lot. But this topic of physical therapy for the pelvic floor region and how central and crucial it is to sexual health is vital, and I'm just delighted that she's here with me today.
Hey, Serena, thank you so much for being with me on the show.
You bet. Thanks for having me.
I am so excited for this episode because I refer to you, but I refer to pelvic PT so often in my practice. You know, it's such an integral part of the work I'm doing with people in sex therapy. So I'm so excited that people can learn more about this and know what's going on.
Without a doubt. We are excited to be getting our name out there more and letting people know exactly what the heck is pelvic PT.
Right. So that's where I really want to start. Like, what is pelvic PT? Because, a lot of people, when I refer them to this, they're like, what? This exists? They have no idea about it.
Exactly. They just go, what? Yeah. Very strange name. So pelvic PT is, most people know PT, physical therapy for the rest of the body. Someone's usually hurt a knee or a shoulder and they go in and they get manual therapy done, either massage or stretching. So in that sense, it's very similar, except that we're geared towards the pelvis. And it's amazing. You can actually do a lot in the pelvis. The pelvis is made up of 3 layers of muscles, 14 muscles total that sit within your pelvic floor, that's housed between those 2 hip bones. And they can create a plethora of issues. So not only of things specific to the pelvic floor, such as bowel or bladder issues, pre and postpartum pregnancy issues, sexual health issues. They can also play into people that have hip pain, back pain, even knee or ankle pain is actually sometimes stemming from the pelvic floor because you have these 14 muscles that also integrate and play with the other muscles of the body. And most people don't realize that. So in pelvic floor PT, we do a pretty thorough exam to look at the whole body and how muscles are working along with those 14, we can't quite get it all 14 in our examinations, but we get darn close, of how those 14 muscles in the pelvic floor integrate and play into the rest of the system. So hopefully that makes sense.
Yeah, in sort of a macro way. And it's interesting because, of course, I'm thinking of pelvic floor PT for the sexual health concerns, because that's what comes into my practice, right? So it's interesting to be reminded, no, it has, that's not all we're doing with our pelvic area, right, is having sex. So
exactly.
Yeah.
That's a big component of it, but there's so much more that people don't realize that your pelvis could be a part of.
Yeah, yeah. So what kind of training do you have to specialize in this? I mean, because pelvic floor, it seems to me, is a narrow specialization within the larger, physical therapy world. What kind of training have you had is required for somebody to, I don't know if you get certified in something like this?
You do get certified typically. There are some people that do practice. I should give a warning and a caveat that you don't absolutely have to have a certification to hang out a shingle and say you do some pelvic floor work. It is still part of the physical therapy world. That being said, most pelvic floor PTs do have special certifications or have done extra training, just because most people that go into it are pretty passionate about it and don't want to go in blind. And so there's a couple different bodies that do kind of a nationwide certification, and those are Herman and Wallace. And then the other one is APTA, which is American Physical Therapy Association. They do different levels of certification. They have a level 1, level 2, level 3 that certifies you to do internal work on the pelvis and really gives you the education and background to understand, like I was saying, those 3 layers of 14 muscles, along with all the ligaments and connective tissue and everything else that plays out there. And so me personally, I did some work along with those organizations, but I did a lot of my training with Kathy Wallace, which, if anybody knows anything about pelvic floor, has probably heard of this woman.
Yeah.
She's kind of the mother of pelvic floor PT and a guru. So she's been my mentor the whole way through, that I feel blessed because I have gotten one-on-one training with this person that kind of started the whole field of pelvic floor PT, which is pretty cool.
Yeah, that is cool.
So I've done a lot of that. And then my specialty is also in more of the sexual pain or pelvic pain, because I also have a degree in human sexuality. And so I've been also doing sexual health education and consulting and or kind of counseling along the way as well. So that's where my specific background comes in.
Okay. Now that raises a question for me, because I'm thinking, well, people that have gone and gotten certified in pelvic floor PT still may not have a ton of training in sexual health. Right. And sexuality counseling. So that's sort of blowing my mind at the moment, because I've thought, oh, every pelvic floor PT must be, really well versed in sex, but that's probably no more true for them than it is for a gynecologist or a urologist or any other medical provider.
Completely. It is not true. And it's very unfortunate. I think that hopefully I will be a proponent of changing that, as I love to also teach and do education. So I'm hoping to do more in the pelvic floor world of really opening up and giving some education towards how do we better treat patients with sexual health issues? How do we communicate about this? And if getting to where they have more specialized training in that, and if not, how to best refer to people back like you that have that experience and the expertise, so that we're working more in collaboration for those issues. Because most you're right, most pelvic floor PTs don't have that training.
Right, right. Yeah, and I've always believed, a little bit of a tangent here, but pelvic floor PT work and sex therapy are such complements, right? Because you're working with the hands-on physical nature of what people are struggling with, along with some educational components and all that. And then sex therapy, especially with a partner, is so crucial for the emotional impacts and what are they doing in the meantime while they're treating whatever they're dealing with. And it's such a beautiful partnership.
Completely,
yeah.
Without a doubt. It's just hand in hand. It's really hard to not treat the pelvis and not have to think of how that's impacting the rest of their life.
Right, right. All right. So who needs pelvic floor PT? Like, what kinds of things are treated? And I'm sort of specifically wondering, what percentage are sexual health related? Just from your own experience, I guess.
Right. Well, pretty much anybody and everybody could probably use pelvic floor PT, whether they know it or not.
Okay. It's a matter of when, not if, is that?
Not necessarily. Some people can go their whole lives and they're going to have a beautiful pelvic floor that never gives them any problems. But for the most part, it's men, women, and everybody in the gender spectrum in between can be benefit from pelvic PT typically. So I'll give you some common examples of what we see and then talk about maybe some of the less common that people don't think about. So
Okay.
common kind of in the female realm is things like pregnancy, pre and post pregnancy concerns that stem into a lot of times incontinence, which there's kind of different types of incontinence, urge and stress, which if people are listening might go, oh, that's me. There's prolapse, which is when organs start to kind of come into the vaginal canal, either your bladder, your uterus, or your rectum. So that's a big issue that we see a lot of. For men and women, and just basically, again, that gender spectrum, anyone in between, we can do a lot of tailbone work. So people with tailbone pain often. We have sexual difficulties. So women that have difficulty with orgasm or have never been orgasmic, sometimes that can come down to the musculature of the pelvis. Men with any kind of erectile difficulties or pain with erection sometimes, or even pain with orgasm, that can go both ways as well. Numbness, tingling anywhere in the pelvis. We see some of that. Bladder pain. We get a lot of patients with bladder pain or difficulty with urination or complete emptying of their bowel or bladders. Bowel incontinence is another one, where leakage from the bowel. Like I mentioned before, sexual pain. So even sexual pain pre, during, or post sexual activity or play. Pelvic pain in general that can come across the pelvic bones, or it feels like it's deep within the pelvis. And so we see a plethora of things come through the door. And like I mentioned before, it can even play into then the hips, back, knees, ankles. And surprisingly, a lot of people don't realize too, I'll ask when I do an exam, I ask about their neck and their head and their ribs, and I actually go and feel those areas because you have a lot of fascia or connective tissue that ties the whole body together and all the muscles. So someone who has neck pain or a rib that's been out of place can actually end up having issues in the pelvic floor because that rib's so far out. And so if I correct the rib, they no longer have perhaps a leaky bladder, or they don't have the pelvic pain they were having, but it was actually stemming from their rib.
Wow.
Or vice versa. It could be the pelvic floor that's somehow pulling on this connective tissue that keeps letting the rib go out of place.
Yeah.
It's actually quite fascinating to really work with the body and see it as a whole and go, there's more here, and we can treat a lot more than we think than just the pelvis.
Yeah, because it's all tied together. It's like you could almost intervene anywhere.
Pretty much.
In a way. I mean, the way you're talking is just like, holy cow, the pelvis. I mean, it's so central, which makes sense, of course, but it seems like it would be worth getting just an evaluation. Like, go up, make sure everything's aligned and functioning the way it should be. Maybe for some of these symptoms that would develop that would bring people in for treatment.
Exactly, because we're all a bit not quite perfect, right? We usually have one ear and one foot that's bigger than the other, et cetera, et cetera. So in any evaluation, we'd be able to find something that's off, of course. But it's when you have certain symptoms that you think, oh, well, I've kind of always had that. But you got to stop and ask yourself, have you really always had it? Did it stem after something? Is it something you want to live with? Is it normal? Should it be normal?
Yeah.
A lot of ladies that get pregnant, for example, and they have leaking afterwards, bladder leakage. And they think, well, I was pregnant, and everybody says, oh, that's just normal after having a baby. Well, it's not normal. It's not inevitable. It's not normal. There's ways to correct that. So you should really consider the symptoms you're having and say, I could maybe stand to get evaluated and just see what my options are.
Right. Okay. So what are some of the early symptoms or mild symptoms that people dismiss and maybe really shouldn't? So you're saying, okay, so maybe some bladder leakage when you think, oh, I'm all stretched out after having a baby. But what are the other kinds of things that people tend to ignore that should maybe just bring them in your door sooner?
I would say anything that's kind of nerve related, which is a lot of like numbness, tingling, any kind of pain, of course.
Yeah.
Leakage, obviously.
Okay.
And just, it's that feeling you usually know in your body. You're like, something's not quite right, but I can deal with it.
Yeah.
I don't know how many times you said that to yourself. I'm like,
Yeah, I've said that occasionally, yes. You to admit it, I have.
Yeah. But I can handle it. Like, no, like that's something to actually look into then. And catching it earlier is better than later.
Yes.
Because you can just do so much more.
So how often, we're getting off the prepared question, so I'm sorry about that. This just makes me so interested and curious.
That's all right.
How often do people see their doctor first and it's the doctor that sends them to you versus people have the idea to even go to a pelvic PT and start there? I mean, what's the usual route of entry?
You're going to get me in trouble with all the medical
Oh,
community.
no. Okay.
People go to their doctors first a lot, and unfortunately, it's changing in areas like Seattle, of course, bigger cities. The doctors are a lot better about saying, "Oh, go see a pelvic floor therapist. Try that first," and that's getting a lot better. But a lot of doctors are just like, you're fine, or they kind of reinforce that idea of it might not feel right, but it's okay. Give it time.
Yeah.
So unfortunately, we don't get as many referrals straight from doctors unless we've personally met them or gone to them and given our spiels kind of thing. A lot of people find us via word of mouth, via social media, online, or they've just gotten so fed up of no one being able to help with whatever concern they have that they just start doing their own Google research.
Right.
And it leads them to us, which is great, but I wish that more of the medical community would really acknowledge us as a first step in intervention or preventative measure.
Yeah, it's too bad all these fields are not more integrated. So, people could cover all their bases easily, without having to do so much research and legwork to do it.
Very much so.
Well, but you did a good job of listing the various kinds of symptoms and conditions that pelvic PT can help treat. So hopefully people will be thinking, okay, if that's me, or if that's me someday in the future, I at least know where I want to start investigating. So
exactly. And I would say too, both individuals in the medical community too, they do forget that we do more than just internal work of the pelvic floor. That we do treat all these other rib issues and neck issues and things. And we look at that. I think a lot of them get sidetracked and thinking, oh, well, I don't know that it's specifically in your pelvic floor, or potentially post a surgery or post childbirth. They're like, it's too early to do any internal work, so you shouldn't see somebody.
Yeah.
We can avoid that section of the exam or that section of work and look at all these other body parts first. So it's really not something to put off.
Right. Yeah, and I would imagine there's more awareness around either sexual pain or incontinence, that might be a more obvious referral. And some of these other things are a little bit more obscure for doctors or referrers. Yeah. Would you say just a little word about vaginismus specifically, because that's the most common thing I refer for.
Yes.
So and you didn't name it, so I just thought maybe you could talk just a little bit about what that is and
yes,
why it's relevant.
One.
Yeah.
We should throw that in there. Things we see: vaginismus, dyspareunia. I don't think they use this diagnosis, but people still say it and use it a lot, as vestibulitis. That's another one.
Okay.
Kind of fall in that same realm of kind of vaginal pain with penetration or burning at the opening of the vaginal canal. Those are kind of the main symptoms of those cases. So a lot of people report they can't use tampons, they can't have any kind of penetration with fingers or other sexual activity, that kind of stuff.
Mm-hmm.
And so that's something we commonly treat too. It should have been in that list I gave you earlier. And it's widely prevalent. And that's where I get on my soapbox with the medical community too, because a lot of times they'll dismiss and say use dilators, if you've heard of those.
Yes.
Or if they've had babies or can get pregnant, they think, well, what's the problem here?
Right.
And that I find very frustrating, because there's so much we can do for those people. And there's so many ways to help reduce that pain or completely get rid of it. And so that you can enjoy these activities and go back to it and have a more fulfilling, if it's a sex life or just in general, because some of these people can't wear tight yoga pants. That hurts.
Right.
So it affects their choice in clothing, which can affect their job sometimes. That if you can't wear tight business casual wear and not be in pain, then what do you wear to work? So there's a lot of factors that come into just a small issue. Well, not even a small issue, but something that a doctor might address as a small issue.
Yeah. And it's not like the goal is, boy, we have to have penetration at all costs, but it's sort of like, it's a whole quality of life issue, and the ability to have it if you want it,
Right.
To have the option and to be pain-free is important, and I start with clients. Some people don't understand that sex is not supposed to hurt.
Right.
It just always has, and they think this is the way it is, and they don't even realize that, there's a problem.
Exactly.
It shouldn't be painful.
Shouldn't be painful.
Yeah.
Exactly. It should not be. And that's
Right.
another one of those things that should not be. It's not a normal.
Yeah.
And there's definitely ways to address it.
Right. Hi, it's Jessa. We're just going to take a quick pause here, or a little breather in the middle of the show. Thanks for listening so far. I'm wondering if you have a question that you want me to answer on a future episode. You can actually record a question for me at our website, bettersexpodcast.com. You're going to find the recorder on the footer of every page and on the side of the episode posts. And if I choose your question, I'll play it on the air and answer it as part of the show. I'd love to hear from you. So what actually happens in appointments? I mean, I would love for you to give listeners an idea of what would they expect, not just in a first session, but in the course of treatment. How does it work? How much touch is there? How much nudity? How much, just have some familiarity about how this works.
No, definitely. That's the people's first kind of, oh my gosh, what am I getting into?
Yeah.
I'm going to a pelvic floor person. They're going to be in my pelvis.
Right.
So it starts with the general, what we call history taking. So my appointments, everybody's a little different. My initial evaluations are an hour and a half, which is a luxury that I get. Some people only get 45 minutes, but I get an hour and a half. So I spend almost 30 minutes just talking about what your symptoms are, what brought you here, kind of a background of your history. I get, of course, being more the niche of sexual health, I do a pretty extensive sexual history of kind of what's going on in sexual activity, how do you define sex, what's working, what's not. And so we do a lot of conversating just around the issue so that I can get a very clear scope of what's going on and what the patient's goals are. What do they want to achieve from therapy? What would they like to be able to do? That's the start of it. From there, we usually go into looking at that whole body. So someone will either be in kind of sports clothing. If they're in like a tank top and yoga pants, that's great. They can be in that. If they don't have that, if they have jeans on or something, it's really hard to evaluate. So I usually put somebody in a gown.
Okay.
Usually with still underwear or bra or something like that on, but a gown over that. So people are still covered. But then we look at the whole body. So we're looking at how the neck moves, how the back moves, how the hips move, kind of all of those things. And we screen through all of that. Once that's done, typically we do a external pelvic exam. So now people stay clothed for the most part, except for the bottom half, so that we can actually look at the structures and the tissues of the pelvis and the surrounding area. And so we stay external and talk the patient through exactly what we're touching and why we're touching. They get familiar with our touch. And then we'll go into an internal exam to check all those muscles, those 3 layers and 14 muscles I talked about. We try to actually go in and see, are the muscles themselves causing an issue? Or some of the fascia, connective tissue, ligaments causing an issue?
Mm-hmm.
And that's a typical evaluation. However, it's not every evaluation.
Right.
Several evaluations, I haven't done any internal work. There's times where it's just not necessitated at that time, or it can be put off later. So it's not a have to. And so if someone's coming in and they're really worried about that section too, they can say, I don't know that I'm ready for that. And we can try to do what else we can up until that point.
Right.
So
Great to know.
It's all about comfort.
Yeah.
And consent. We talk a lot about consent. So before each step of my exam, I always make sure they know what we're doing next and ask that they're okay to move forward. And then in follow-up appointments, my follow-ups tend to be an hour, which is again a luxury.
Yes.
Some pelvic floor PTs only get 30 minutes, which I think is way too short. And so in follow-up appointments, we will often work on things of, sometimes it's just doing exercises for the rest of the body, because if the neck or the ribs, a lot of times the glutes, the butt is really involved in pelvic floor issues. So we work on exercises to strengthen all these other areas. A lot of breathing and breath work happens.
Mm-hmm.
Sometimes we get into, for a lot of kind of, if I go back to the vaginismus or some of the sexual health ones, A lot of times we have to do further internal work. Just like your back can get a big muscle knot in it. And a lot of people have probably been to the massage therapist that kind of gets an elbow in there and works out that knot.
Right.
The same thing can happen in the muscles of the pelvic floor. So sometimes internal work's needed to release some trigger points, if you will, some of those knots in the pelvic floor. So sometimes that could be in a follow-up appointment, but not always.
Okay.
We do a biofeedback where we can hook up to a machine that has little external sensors that sit on the outside of the skin that can measure how contracted your pelvic floor is or how relaxed. And so that's pretty non-invasive, and we can really get a good picture of what the pelvic floor is doing.
Okay, so those are like those, I mean, I'm imagining doctor shows because I've not had this done, right? Little sticky things that go on the outside of the pelvis and are able to measure all that. And then the people are looking at the monitor with you and learning.
Yeah, they get to see on the monitor kind of in real time what their pelvic floor is doing. So it's pretty cool. They can see if it's really tight and held. And by watching the screen and breathing, they can learn how to relax it.
Okay.
Or they can learn how to squeeze and watch this big contraction happen on the screen, which is kind of cool. So,
okay.
And then it has different programs. Sometimes our newer biofeedback program, you can do fun games like watch a dolphin jump through a hoop, and every time you make the dolphin jump through the hoop.
Oh my gosh, they're making video games out of everything, huh?
Completely.
But it would be a little bit more fun, I suppose.
It's more fun than just sitting there and squeezing. So, so there's lots of interest there, which brings up everybody's usually heard of Kegel, right?
Yeah.
So Kegel means squeeze, squeeze, squeeze. And it's interesting because that was such a big push. Everybody needs to Kegel. Women need to Kegel, da, 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 da. And now they're finding that most people probably shouldn't be Kegeling. That most people have a very tight pelvic floor.
Oh, wow.
That because of the way we live our lives and have lifestyles, that we tend to be clinchers of our pelvic floor and our butts. And we actually need to learn to relax our pelvic floor more than we need to learn to tighten it.
Wow. Okay. I had not heard that. I guess I'll stop, at least until I've been evaluated.
Yeah, exactly. And the other part of the Kegel is because you have those 3 layers of muscle, that most people get the 3rd layer because it's the biggest and strongest, and that's what they squeeze in a Kegel. But there's actually 2 that sit more in the front of your pelvis that most people kind of miss. So it's actually quite interesting.
Wow.
It's a lot more involved than what we thought of back in the day of just being like squeeze. Just
right.
Yeah.
And then is dilator therapy part of what you're doing with people too? I mean, you mentioned that with doctors might just say, oh, get some dilators and go to town. But is that a part of the work you're doing as a PT?
Yes. So we do use dilators sometimes, which if anybody doesn't know, it's kind of there's a plethora of dilator types out there, but they can, I'm not sure what all I'm allowed to say on here. They can
no, go ahead. Yeah, this is explicit.
Okay. They can be soft or hard, but they typically kind of a dildo shape. Some vibrate, some don't. There's just all sorts of varieties. And they start usually in small sizes, really tiny up to pretty large.
Yeah.
And let's go different ways. And so when doctors say just get dilators, it's really hard because what do I do with this thing? So our treatments and our style is to really step through the different ways you can use the dilator and how to stretch the vaginal tissues, how to stretch anal tissues, or do these different things with dilators to make room and relax the pelvic floor at the same time. So there's actually quite a nuance to using dilators that is more than just get some and stick them in.
Yeah, read the instructions that come in the package and go, right? Yeah. It needs more support than that.
Exactly. So we do a lot with that. And alongside of that is, education and talk instruction on lubricant choices. Diet can play into that too. What are you using diet-wise to help lube through the pelvic floor and create better tissue hydration, that kind of stuff. So there's a lot that can play into it. And we do that nuanced little itty-bitty instruction on the side, not just here's some dilators, let's go.
Yeah. And part of what I see in my practice, and I'm sure you deal with it too, is the emotional support of using dilators. I mean, if somebody's doing that for pain, it's intimidating to start to work with something that they may think about inserting, so
completely.
It's not typically a go do it yourself kind of project, right? Because there's support needed for how to do it and then how to handle it emotionally and deal with it with your partner too.
Oh, without a doubt. And they're usually, in those cases, not something I introduce in the first couple sessions even.
Yeah.
We're not like you said, there's such an emotional component that we're usually not at a place to start using them that soon.
Yeah.
If we need to get some other things on board and kind of decrease any fear, any pain associated with that kind of penetration, and then slowly add it back in a way that's pain-free.
Right. So that brings me, I've got an extra question for you now, because I'm thinking about some of the people that have come into my practice. They've seen a physician, maybe. They've been told to use dilators. And the way they're at least reporting it to me is it's been described to them that they just need to stretch out their vagina.
Oh, yeah.
So, and that's what these are for. It's not even so much about being pain-free, but you need to be stretched. You're just too tight. And once you're stretched out, you'll be ready to receive whatever it is you want to receive inside your vagina at that point. And I thought maybe you could speak to exactly how this actually works and what's going on.
Yes. And
I know. I know. It just kills me every time I hear this.
Yeah. Again, hopefully not too much medical community listens to you.
Well, no, hopefully they are, because it's, I think it's a common misconception, and it's not really their fault. They haven't had the training that they may need for this. So
that is true. Yeah. So it's not always just a stretch issue. Tissues are pretty pliable, and so it's not usually a stretch issue. That's a component of it, but it's more, I would almost say it's almost more the emotion and what we call, like some of the new research out is the neuroscience of pain, of how the body interprets and processes pain signals and then creates guarding patterns. And that happens a lot in the pelvic floor. And so a lot of the newer research is actually pointing to doing breath work and visualizations rather than actual stretch or manipulation of the actual tissue.
Yeah.
It's a matter of the person becoming comfortable and understanding, because a lot of times you can ask these clientele or these patients, I'll ask them during their exam, if you just picture me touching or yourself touching or your partner touching, do you feel pain? And a lot of times they'll say, yes, I do. So there's a clear signal that something in how the brain has processed through that pain in the past to set up a kind of a pain loop, if you will, that those tissues are already painful before stimulus has actually been added.
Yeah.
And so to go in and say, put a dilator and then just stretch the tissues, you'll be fine. That's going to cause so much pain.
Right.
And just
which then reinforces this whole cycle, right? I mean,
correct.
Yeah.
Correct. So a lot of times it comes down to re-educating the brain through different stimulus and different activities to change how the brain's processing its input. It's real pain that they're feeling. I don't discount the real pain they're feeling, but we got to change the way the brain gets the input and processes it. So that's one approach. Another one is actual physical stretch or manipulation of the tissues to give that input. And that can come from the hands or the dilator. And again, that's not usually in the first couple sessions. It's down the road.
Right.
And sometimes it's a matter of the partner being a part of it too. Sometimes I have partners that attend sessions because having them help with that treatment or be a part of it and learn how to touch their partner in a way that's not painful is a big portion of that healing.
Right. Right. And I work with couples around this all the time, right? It's one thing for, the female partner who's having the pain to sort of relax enough to accommodate the dilators. It's a step to let someone else penetrate you, right? Emotionally and psychologically, that is a different thing. So getting a partner involved at some point, it's got to be part of the process before you just jump into sexual activity or something. Yeah.
Oh, yes, because that's the hard part. You can anticipate your own touch or your own touch using a dilator or some other thing, but having somebody else come in and try to touch you without warning, I mean, even if you know that you're starting to involve yourself with your partner, it's big.
Yeah, it's really big. And that's something that, I think a lot of people are kind of missing as they're trying to work on some of these ideas.
Yeah.
So, yeah. And the other thing I try to tell people, and correct me if I'm wrong, but it's not like we stretch out our vagina and then it just sort of stays there open, right? It's not a matter of stretching it in that sense. To me, it's a matter of relaxing while you stretch so you can do that next time. I mean, a vagina comes back together when nothing's in it.
Oh, yeah. Very distensible tissues. Vaginas and anuses are very stretchable tissue, and they stretch and then they kind of relax back to a baseline position. And so, you can stretch and you can stretch, but you're not going to like outstretch your vagina. Now it's escaping thing that's just
right.
A flap in the wind. That doesn't happen.
Yeah.
So it's you're right. It's more about the relaxation of allowing those tissues. Cause like I was saying earlier, most people are really tight in their pelvic floor.
Yeah.
It's learning how to relax those tissues enough to take penetration or to be manipulated, and then they don't stay
Yeah.
down. Like the stretch is kind of a misnomer. Stretch is a bad word.
Yeah.
Relax is a much better word.
Right. All right. So how does somebody, I mean, if someone's in Seattle, lucky enough, they can find you. But how does somebody find, a qualified pelvic floor physical therapist?
That's tough. But if both those certifying bodies that I talked about earlier, Herman and Wallace and APTA, they both have listings of providers that have been certified through them.
Okay.
So a good resource that I believe you include at the end of the podcast of where to find a provider that has been trained through those facilities.
Yeah, we'll put links in the show notes for people for that.
So there's those two. Otherwise, it gets a little bit tougher. A Google search will provide you probably some local area people. You would have to then research them a bit to see what their certifications and our trainings are. But that's always an option. And otherwise, there's not really a great way to...
Yeah, it's not like you can do this remote over the internet or something like that.
No, it's pretty tough. Any hospital, usually, most of the hospitals these days, at least in Seattle, so I'm assuming in a lot of the other cities, will have a pelvic clinic in their hospital that treats pelvic floor concerns. And usually if they're hospital grade, they have to have some kind of certification to even work there. So
okay.
And most hospitals will cover insurances, whereas not all the outpatient private clinics, for example, ours, doesn't cover as many insurances.
Right. Okay.
So there's that.
All right. And do you want to say just a little bit about the clinic that you've got and working with you, how people can learn more?
Definitely. Best way to see us is www.pelvichealthclinic.com. It gives a little bit about each of our providers and more about kind of our philosophies. But what we are also considered an outpatient pelvic floor physical therapy clinic that does fee for service is what we're called, which is good and bad in the sense of we do not bill to insurance directly, which can be a little daunting. If people are in a real financial hardship, we do try to offer sliding scale and things like that because we're not trying to keep anybody from their care.
Right.
And we do have a lot of patients that at the end of a session, we can provide what's called a super bill that they then submit to their insurance and get some reimbursement back. So
right.
Because we're fee for service doesn't mean that your insurance might not cover some of your visit. But a lot of the reason I went into a clinic that does fee for service is because of my sexual health background that, as you know, insurance is not a big fan.
Right.
We start sticking sexual health things on anything. Insurance gets really weird. So another soapbox I could go on and on about.
Yeah.
But it allows me, being in a clinic like this, allows me to treat the person in front of me in the best way that they need. So if that's more sexual health intervention, we can go that direction. If it's more straight PT, kind of that muscle manipulation or exercises, we can go that way. But it gives me the freedom to really give the patient what they need most instead of being dictated by insurance to say I need to do these particular things in order for them to get their money.
Right.
So it's a catch-22 in a way, but I appreciate that freedom. And I think most of the people that we see here really appreciate that freedom.
Yeah. Great. Well, thank you for this. I think this is just such an important conversation. And I'm just delighted that we managed to fit this in before you have your baby. So
Thank goodness.
So we'll have you back someday too. Once you're back from maternity leave and we'll go on.
That would be excellent. Thank you so much for having me.
Yeah, thanks. Bye-bye.
Bye.
You've been listening to Better Sex. Please visit our website, bettersexpodcast.com, for show notes and additional episodes.
And that's a wrap for today. I really hope you enjoyed the episode. If you are enjoying the podcast, if some of this material resonates with you and you would like to make a difference and make sure that this keeps coming out in the world once a week, ongoing, there are a couple things you could do to show your appreciation. The first would be to go to iTunes and rate and review the show. That really helps us be found by new listeners when you review the show on iTunes. You can find a link at bettersexpodcast.com/iTunes. The other thing I want to invite you to consider is becoming a Patreon. For a small monthly pledge, you get some benefits. So for $2 a month, you get advance access to every single episode. For $5 a month, you get a chapter of my upcoming new book. And for $10 a month, I host quarterly get to know you and question and answer chats over the web, and you get invited to that. I would love to have your membership in that, become part of the Better Sex family. You can find a link at bettersexpodcast.com/Patreon, which is Patreon. Again, thanks for listening. I'm glad you're here. Feel free to comment, ask questions, get in touch. I'd love to hear from listeners. Thanks.